Welcome to Providing Mental Health Services for TANF and Other Low-Income Participants webinar. My name is Jennifer Gillison, and I am from Kaufman & Associates, and I will be your moderator today along with Carol Mizuguchi. And let's start with explaining a little bit about the webinar interface. You should all see the first slide of the PowerPoint presentation in the Q&A box to the right. We'll be answering questions at the end of the webinar, but you can enter a question at any time. If you need technical assistance during the webinar, please use the Q&A box. Please note that this webinar is being recorded. I will now turn it over to Carol Mizuguchi.
Good afternoon, and thank you for joining today's webinar, Providing Mental Health Services for TANF participants. We are excited to have a panel of expert presenters to discuss this critical topic with you today. My name is Carol Mizuguchi. I'm from the Office of Family Assistance, and I'm going to be one of the facilitators today. So many of you attended the Office of Family Assistance Gateway to Opportunity, Improving Parental Employment and Family Well-Being Outcomes convening in Washington, D.C. last fall. During that national meeting, we held a workshop on integrating mental health services for TANF participants through ACA collaboration. This topic remains a critical and timely component of a responsive TANF program, and OFA wanted to take this opportunity to continue the conversation. This webinar offers us an opportunity to share the latest policy and program ideas around the provision of mental health services to TANF participants. We know that individuals with mental health conditions are more likely to be poor and unemployed, and that an estimated 1/4 to 1/3 of TANF participants have a mental health condition that can become a major barrier to consistent employment. Since the passage of welfare reform in 1996, jurisdictions have had to rethink their approaches to providing mental health services to TANF participants in order to comply with work requirements. However, mental health issues are nuanced and complex and need to be addressed with a holistic understanding of their pathways of influence on families. For example, having a depressed parent puts children at high risk for behavioral problems and mental health illness themselves. PRTA has seen many questions over the years on strategies for coordinating mental health services for TANF participants, and a number of states have taken steps towards conducting mental health screening and assessments, developing supportive services, connecting recipients to SSI benefits, allowing recipients to access state-funded programs, and linking recipients to skilled mental health professionals. Our conversation today will focus on understanding what has worked to help caseloads with mental health needs. Should the focus be on mental health first or concurrently with employment services? And how can TANF agencies work more effectively with outside partners to coordinate services and approaches? Our learning objectives today include understanding the challenges TANF programs face in providing mental health service, progress made in states since welfare reform in 1996, and newer implications and opportunities for collaboration in the context of policy changes such as the Affordable Care Act and the Workforce Innovation and Opportunity Act. We'll also hear about experiences and lessons learned from programs that have taken different approaches to addressing the mental health needs of TANF participants. And finally, considering your own TANF program population and whether or not there are any insights you can take home to improve or better streamline your jurisdiction's connections to mental health services. So as I mentioned before, we're fortunate to have a wonderful slate of expert speakers. And first we're going to hear from Dr. Mary Spooner. Dr. Spooner is a senior manager with ICF International. She is a senior manager. Have a repeat. She leads several mental health related projects. Her experience spans evaluations of system transformation initiatives in health, education, and criminal justice sector. She currently leads multi-site evaluations of system-wide interventions that serve children exposed to violence and children with serious emotional disorders. Dr. Spooner will provide an overview of the implications of addressing mental health needs among TANF participants and offer insight into the structural and perceived barriers to mental health services access in a TANF setting, based on our own work with TANF families and other low-income populations. Dr. Spooner also holds an adjunct assistant professor position at the Northwestern University School of Medicine, where she teaches a graduate course in U.S. mental health policy. So she speaks to change and new opportunities in state practices across mental health systems in the context of recent federal policy changes, such as the Affordable Care Act. And then we'll hear from Timothy Cantrell, who is the Assistant Deputy Commissioner for the New York City Human Resources Administration Office of Rehabilitation Services, and also the Director of WeCare Operations. WeCare, or the Wellness Comprehensive Assessment, Rehabilitation, and Employment Initiative, provides clients with a comprehensive biopsychosocial assessment conducted by a licensed social worker and reviewed by a physician, as well as a full vocational evaluation that identifies each client's strengths, skills, and aptitudes. New York City partners with a number of vendors to serve TANF participants with behavioral health conditions and offers a range of services to help participants achieve their employment goals. WeCare has presented with OFA before, and we're excited to have them back today. And finally, we'll hear from Miranda Gray, who is the administrator for the Reach Up program under the Vermont Department for Children and Families Economic Services Division. And Reach Up is Vermont's TANF program, and it takes a unique approach to mental health service provision, including substance use services through direct partnership with the Educational Rehabilitation Agency. Ms. Gray has worked for the state of Vermont for 8.5 years. She's a graduate of St. Michael's College with a Bachelor's of Arts degree in psychology. She began her career providing direct services to TANF clients at the Orange County Parent-Child Center. In 2007, she began her career with the Agency of Human Services as a Reach Up case manager. She has worked since 2010 in Reach Up Central Office, interpreting rules and providing guidance to line staff. And more recently, she's had the opportunity to oversee Vermont's Reach Up Substance Abuse and Mental Health Program, which was established in late 2013, among other grants and contracts that support Vermont's TANF program and the clients they all serve. So, as you can tell, we have folks with a lot of experience, and so we're excited. So before we begin the presentations, we have a poll question, and so I will just ask the audience to respond, and then we'll look at the responses, and then we'll go ahead and have Mary do the presentation. And I think I'm supposed to move these slides, and I haven't. There's a slate of the presenters. And here's the first poll question. Do you or another member of your team or did you or another member of your team attend the Providing Mental Health Services for TANF Participants workshop at OFA's Gateway to Opportunity National Meeting? And I guess a large majority did not attend, so some of this will be new information. Most of it. Okay, so we'll go ahead and Mary, you can go ahead with your presentation. Thank you.
Thank you, Carol, for the introduction. I'm happy to be able to participate in this webinar today, and I hope that we can have a good discussion about mental health, the related challenges, and on a more positive note, the supports that are in place to help TANF and low-income families. If my voice drops, just let me know. As the title of the slide indicates, I'll be talking about the implications of providing mental health services for TANF and low-income families. But first, I want to give you an idea of what you can expect during this presentation. First, I'm going to talk a little bit about the definitions of mental health, mental illness, and mental disorders. We look at the prevalence of mental health and substance use issues, talk a little bit about mental health and the well-being of TANF recipients, the challenges in providing mental health services for these populations, and a few of the mental health focused policies and initiatives that are out there, and some policy recommendations. Generally, when I make presentations of this nature, I like to focus attention on what we mean by mental health and mental illness and those differences. Unfortunately, because of the images of the media and so forth, mental health gets linked very negatively to issues related to violence and so forth. But when we talk about mental health, we're really talking about a state of well-being in which the individual realizes his or her own abilities, can cope with normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So when we talk about mental health, we are talking about overall well-being, and not just the absence of a mental disorder. When we talk about mental illness, we're talking about the collective diagnosable mental disorders. And when we talk about those disorders, that's when we're talking about the health conditions characterized by alterations in thinking, in mood, behaviors, etc., associated with distress or other impaired functioning. The truth is that mental health and substance abuse appears all around us every day. So let's look at this slide that shows the population of adults and children impacted by mental health and substance use. And I'm leaning on SAMHSA's 2014 report of past year substance use disorders and mental illness amongst the adult population here. And what those data tell us is that 43.6 million adults had any type of mental illness in the past year. 9.8 million had a serious mental illness. 20.2 million had a substance use disorder. But when we dissect those populations, we can see, based on this graphic, how this falls out. So in the big blue circle, we have 35.6 million persons with mental illness with no substance use disorder. On the far left, we have 12.3 million persons with substance use disorders with no mental illness. And then we have a co-occurring group in that green shaded area that represents persons with substance use disorders and mental illness. That is a huge population of persons. And if we are thinking in practical terms, this represents the population of a state such as Washington. So, what is the prevalence of serious emotional disorders among children? Just over 20% of children 13 to 18 years currently or at some point during their life had a seriously debilitating emotional disorder. And I want you to bear this in mind because it has bearing on our later conversation. Roughly 10% suffer from a serious disorder that causes substantial impairment in functioning at home, at school, and in the community. And using data from one of the evaluations that I manage, we found that 6% of the children 0 to 21 who were served by systems of care, which I'll talk about a little bit later on, were from families that received TANF services. So what's the prevalence of mental illness amongst TANF recipients? 44% of all recipients reported at least one physical or mental impairment based on the U.S. General Accounting Office's report in 2001, and 36% reported either very poor mental health or that health limits work. Looking at the prevalence of substance use, about 20% of TANF recipients reported that they have used an illicit drug at least once in the past year. Approximately 5% reported illicit substance use or dependence, and 6.5% reported alcohol use or dependence. I want to talk a little bit about adverse childhood experiences, because this has some implications for the mental health and well-being of the population. Looking at the pyramid on the right and looking at that arrow next to it, we see that families may be exposed to adverse childhood experiences that start very early in life, looking at conception all the way up until death. And as a result of those adverse childhood experiences, families go on to experience disrupted neurodevelopment, social, emotional, and cognitive impairment, adoption of health risk behaviors, disease, disability, and social problems, and this often leads to early death. Almost 2/3 of the study participants reported at least one ACE. And an ACE is an adverse childhood experience, which could be anything such as child abuse, neglect, physical, sexual abuse. All of those behaviors or childhood traumas are described as adverse childhood experiences. What the researchers of this Kaiser population found is that as the number of ACEs increase, so does the risk of the events in that pyramid. And this is extremely concerning as it relates to mental health, particularly as we find that Kessler and his team uncovered the fact that 50% of all diagnosed mental health concerns were found in adults had started by the age of 14 and 75% by age 24. So these conditions are present very early in life. Moving to the next slide. So what does this have to do with the TANF population and their experiences? The truth is that poverty, as I represent here, these 4 pillars in this matrix, in many ways determines the actions and behaviors of low-income populations. As the cornerstone of the life experiences of low-income families, but it is complicated and at the same time it complicates the lives of families. So when you look at a matrix like this, there's a relationship between all of these factors, and all of them are influenced by poverty in one way or another. These links are sometimes obvious, as indicated by the firm line, and not so obvious as indicated by the broken line. Families caught in this poverty maze may find it difficult to get out of poverty and to seek any type of help, mental health, work, any of the other resources that may be out there, unless they have the required support. So, for example, a deficit in income affects families' ability to provide for basic needs such as housing, food, health. Access to housing, we know, determines the type of neighborhoods in which families live, and the fewer assets in communities, the greater the challenges for raising children. In the absence of parks and open spaces, for example, children are less likely to thrive and experience good all-around health. Access to housing determines where children go to school and the quality of education they receive, and the potential for employment that will later lift them out of poverty. Poor neighborhoods are also the places where families often encounter experiences of the trauma of community violence. Lack of resources, in many instances, may be associated with experiences of domestic violence. Poor physical health impacts mental health and vice versa. And for many, employment is not possible if there's a child with a physical or mental disability, and we saw the numbers just now. In these circumstances, daycare may not be possible if the flocks in the neighborhood are full, if they can't afford to pay for daycare. So what we know is that having chronic mental health conditions in childhood is a significant predictor of mental health disorders later in life. Low-income women who are not working, who are TANF sanctioned or experiencing housing instability are more likely than others to report substance abuse. Substance use is also associated with increased duration and cycling on and off TANF. And substance use together with mental health issues creates serious problems. So what does all of this have to do with accessing mental health services? The fact is that there are many barriers to families receiving services, even if they want to go out there and access those services, and that has to do with the stigma around mental health, also about the denial that many persons may be in about their mental health needs. This is particularly true in case of young persons who are often difficult to convince about their need for mental health services. Sometimes systems are difficult to navigate. You have to go from one place to the other in order to get services. And then sometimes transitioning from one system to another is difficult, especially when you're talking about young people moving from a child system into an adult system. The financial costs of mental health services are also a deterrent to seeking help. The ACA has helped some, but there's still challenges, particularly in states where Medicaid has not been expanded. In terms of unemployment, many families in this country receive services receive mental health coverage because they are employed. And then there's always that issue of lack of trust of systems and providers. So, what are some of the mental health focused initiatives that are out there? There's the screening, brief intervention and referral to treatment initiative. And this allows for quick screening to assess severity of substance use and referring persons to treatment. There's also systems of care for children with serious emotional disorders, and I think every state in the country has systems of care in some form, either because they have been earlier recipients or because they're now expansion grantees. And those are coordinated networks of community-based services that support children with serious emotional disorders and their families. There's mental health first aid, and this is targeted for adults as well as to young adults. And mental health first aid provides training for persons in the community to identify persons in mental distress and provide support and referral. And this targets first responders, teachers, and other persons of that nature in the community. There's a Safe School for Healthy Students state program, which provides mental health services in schools so that children and youth have access to services, but also to ensure that schools are safe and are conducive to learning. There's also the Now Is This Time plan, which is the President's plan that was introduced some time ago to address gun violence with provisions for providing mental health services with a focus on that transition age population, 16 to 25 years, at risk of mental illness. It also covers mental health first aid training for teachers, provides school resource officers, and other safety features. An emerging initiative is the evidence-based treatment for first episode psychosis, components of coordinated special care, and this is an initiative coming out of NIH research, and it's really a collaborative recovery-oriented approach to involving clients, treatment team members, and relatives as appropriate as active participants in the care of persons with first episode psychosis. Then there is the Community Behavioral Health Clinic, and I think Miranda is going to talk a little bit about that. Section 223 of the Protecting Access to Medicare Act. And this helps states to establish certified community behavioral health clinics, and they provide programming to integrate behavioral health with physical health and increase consistent use of evidence-based practices to improve quality of care. There are also private initiatives from foundations, such as Annie Casey, and they have initiatives that try to address children's mental health and disconnected youth and so forth. So in thinking about mental health and engaging these populations in mental health services, recommendations would focus on things like resetting the frame of reference for mental health in terms of that definition I presented before, and it's about the coping, and it's about helping people to be more productive. Understanding the culture of poverty, understanding where people are, that they have to be met where they are, understanding the challenges related to the status they have and why they are in that particular situation, using a strengths-based approach which tells people the positive aspects of their lives and where they can go next. Building trust. Many people, for whatever reasons, are skeptical of systems that, even if they're there to support them, they don't trust those systems, and it's about gaining that trust. The other recommendation is about providing integrated care. This has become more and more popular. Previously, I'm sure many in this audience will know that you couldn't provide mental health services and substance use services together, and you couldn't use those words in the same sentence. And that's changing, and people are talking about integrating care and collocating staff, mental health staff, in physical care services. Also, providing the types of clinical assessments that will help to identify persons in need of services and linking them to that treatment, and making those the services culturally appropriate. Because in many instances, services are not culturally appropriate. And when I say culturally appropriate, I'm not talking about translating forms into Spanish or translating forms into something. Many people say, well, it's culturally appropriate because we have everything in Spanish. No, it goes beyond that. It's about understanding people's issues that are related to socioeconomic status, to the race, ethnicity, to communities, understanding what works for populations. And then the other thing is about wrapping services around the family. The truth is that working with these populations, you have to take them as a whole package because services have got to be wrapped around. Many of the children who have serious emotional disorders, their parents have some sort of mental health disorders. And parents that have mental health disorders, their children have some serious emotional disorders. So it's about wrapping services around the family, knowing that together they make a family unit and everything affects everybody in the unit. And then the other thing is promoting interagency collaboration. So much of my work is about understanding collaboration between agencies, and so much of my work continually shows this tension in collaboration between agencies and who's at the table and who's not at the table and why this agency is not at the table. And it's about now thinking about how agencies can work collaboratively for the benefit of families. And particularly given the challenges associated with these populations, if they're going to be able to access mental health services, it's going to have to be as a team effort between all of the sectors that serve these families. So that's my presentation. I do want to leave with you this little mantra from SAMHSA, which I like very much. It says behavioral health is essential to health. Prevention works, treatment is effective, and people recover. And so I am going to turn the presentation over to the next person. Thank you very much.
Mary, thank you so much for that presentation. That was great. So now we have, before we have our next presenter, we'll have our audience poll, and they moved ahead of me. They've, looks like the majority of the folks, the large mental health is significant amongst their participants, so with their TANF population, 88.8%. Okay, thanks to the audience for participating in that. So next, we are going to hear from Timothy Cantrell. I'll turn it over to him.
Good day, everyone. Very happy to be a part of the panel this afternoon. And I'll be discussing what I hope will be a useful, practical example of working with mental health conditions while in TANF programming. Specifically, I'll be primarily speaking about the We Care program in New York City. So early in the 2000s, around about 2006, New York City Human Resources Administration recognized the fact that we needed a specific way to address those people who had either medical or mental health barriers, clinical barriers, to finding employment as a part of welfare reform. Each year, the We Care program in New York City serves over 50,000 people. And those basically include anyone who is declared, anyone who is not exempt from program activities, anyone who's declared that they have medical or mental health issues that could prevent them from going back to employment. So we have developed an integrated model of service which provides vocational rehabilitation, wellness services, disability application services, and other wraparound services to help those people not disengage from trying to find employment, but ultimately either change their condition or learn to work with their condition so that they can get back into the workforce. One key thing to realize about the We Care program in New York City is that we don't provide any direct clinical services. We focus on assessment, and we focus on referring to other care providers or making those connections where those are necessary. The We Care program itself is operated under contract to the agency, and it is a performance-based contract. It is 55% performance-based where the contractors only pay if they achieve certain milestones such as successful SSI applications, successful completion of the wellness plans, or placement with retention. And I'll get into each of those types of services in just a moment. The program itself, as I said, serves over 50,000 people a year. There's over 500 staff under contract to us with the vendors who provide the services. The staff themselves are a very interesting mixture of case managers and qualified health professionals such as licensed master social workers, LPNs, RNs, and MDs. So the model that I've put up on the screen for you at this time is the overall view of how WeCare itself works. So any new client, again, who has said that they have a medical or mental health condition which precludes them from engaging in the workforce, receives what's called a biopsychosocial. So there's a number of different components of this. The first is a psychosocial assessment by a social worker, which goes through whatever barriers they may have in their lives, their activities of daily living, their education, their home life, their work experience, any of those social factors which may be impacting their ability to re-engage with the workforce. Following that, they receive a full medical examination by a licensed physician. That lasts anywhere between 20 and 40 minutes, where the client's health concerns are reviewed, plus the physician looks for anything else that the client may be unaware of or simply hasn't mentioned. In conjunction with that medical exam, standard lab are performed. So we do blood work and things like that as well. Then also brought into consideration is any documentation that the client brings in. We encourage them to bring in anything that they may already have from the treating physicians or any programs that they may be in, so that we can review that in addition to our own examination. Based on the results of this initial assessment that we go through, which takes place in one day and can take up to about 3 to 4 hours, depending on the amount of time that the customer needs or the client needs. We may or may not be in need to do an additional assessment on the customer. And those additional assessments can include psychiatric. They can include orthopedic. Those are by far our most common. Every now and again, we'll see people who need a follow-up cardiology, endocrinology, something like that. So if the initial physician is unable to really come up with a clear assessment, we do refer to a specialist so that we get a clearer picture for the person. The complete time for the assessment to review all documentation and come up with a determination of where the person best fits in our program can take up to 10 days, but most commonly all documentation and results are reviewed in about 3 to 4 days, resulting in something called a functional capacity outcome, an FCO, which is basically what is going to be the best service track for this individual. In addition to the medical assessment and the psychosocial assessment, if necessary, we do have CASACs at each service site, at each medical assessment site, I should say, where if there's a history of substance use within the past 12 months, or if the individual indicates that they are currently using substances, we refer them to a CASAC to see if that is something that needs to be taken into account in the service plan. And one other key piece of analysis that's done in coming up with an appropriate FCO is something called a sequential evaluation. The sequential evaluation is a multi-step process used by SSA to determine whether someone is appropriately or would best be served by SSI or rather eligible for SSI. In the sequential evaluation, the physician takes into account all the information that I've just gone through. And first of all, compares against what are called the Blue Book listings, see whether the client meets the specific criteria to be eligible for SSI because of a specific heart condition, let's say, or because of a specific orthopedic condition, or a specific psychological condition. If they don't meet the specific criteria for a listing, then the sequential evaluation goes on to look at what are called the grid rules, where the combination of the client's age, work experience, educational background, exertional and non-exertional limits, and whether they will be able to continue to do work that they've done in the past are all taken into account to see whether, again, if we're not meeting a specific condition, whether this person, because of the combination of these things, is someone who cannot reasonably be expected to engage in the workforce for at least the next year, and in which case SSI is a better determination for them. The FCOs that can come out of this process, one of which I just mentioned was federal disability, that we will refer them down the SSI track and help them in their SSI application. We may have people who have medical conditions that are not permanently disabling or disabling for up to a year, but are temporarily disabling. For example, someone might have a broken leg, or someone might have a psychiatric condition and they're just starting to see their psychiatrist and take medication, in which case they may not be able to re-engage with the workforce for 30, 90, 180 days, in which case we will issue what's called a wellness plan for them. So this is to help someone who is unstable in whatever their current medical or mental condition is, and is expected to improve over time such that we can, at that point, re-engage them in trying to find work. We also have a combination of those two tracks called Wellness Plus, which is basically someone who is eligible for SSI potentially according to the sequential evaluation, but also has a temporary condition that requires a wellness plan so that they can address it. Otherwise, we have two other options for someone who comes through the assessment process. One is vocational rehabilitation. This is where the client is deemed to be employable, but with specific limitations. So, for example, it might be someone who has an orthopedic condition where they cannot work in a warehouse anymore, but they do have skills that are transferable that help them to find other work. Lastly, we do have people who come through the assessment process who are deemed fully employable without limitations, in which case they are not engaged in the WeCare program, but rather sent to one of our counterpart programs within the agency, the Back to Work program, which works with people who are fully employable. Before I go into each of the specific tracks and how we work with them, I should mention that we also have something called a clinical review team. People's conditions are not static. They change over time. They get better and worse as people go through the program. But we always have the ability within the program to review someone to a clinical review team, which again is consists of qualified health professionals, to see what the change has been for them and whether we need to reassess functional capacity to which they've been assigned. So as I mentioned, one of the simplest FCOs is the fully employable FCO. This is a case where the physician has reviewed all information, sees no reason that they cannot participate in the regular HRA employment programs, and they are referred outside of WeCare. The wellness track is where the client needs medical treatment to stabilize the condition. So they come in after receiving their FCO designation, and they meet with a case manager who specializes in wellness plans. And this person will perform a number of functions to help them come to the point where they can engage with their job search. First of all, they'll link the customer or the client and collaborate with appropriate treatment providers. So if someone comes in, they don't have a current treating or primary care physician, we will make referrals for them or to specialists so that they can find someone who can help them with their situation. We provide health education information that may be relevant to specific conditions. We monitor and facilitate compliance with and progress in medical treatment. So when someone is on a wellness plan, we check in with them minimally every 30 days, if not more often, to make sure that they are making their appointments, that they are progressing in their treatment, and to see whether we need to adjust anything in their specific treatment plan. And that's all a part of the ongoing case management process, reminding them about appointments and making sure, again, that they've got all the providers and resources that they need. At the end of a wellness plan, their status is reevaluated. This is generally done by the physician who first assigned them their FCO. They take a look at any new medical documentation that's been collected and submitted as a part of the wellness plan. And they also look at a key document, the treating physician wellness form, which comes back from whomever their primary care physician or physicians are. With that physician's recommendation to whether this person is ready to go back to the workforce or whether some other track is going to be more appropriate to them. At the end of a wellness plan, which again can generally last no more than 180 days, they're deemed either fully employable or sent to rehabilitation or deemed ready to go into disability at this point. The vocational rehabilitation track is going to be a track where someone is going to be involved for all of their participation hours during the week in their job search and in training. So they're employable within limitations. And the first step in this process is that they come in and they go through a diagnostic vocational evaluation. This generally takes a day. It can take a little bit longer depending on the specific situation of the individual. And it's a full assessment of their skills and their interests. And basically taking a look at what's going to be the most appropriate type of employment for this person given the current medical and mental health conditions. If necessary during the DVE process, we may perform a sequential evaluation again. We see, given everything that we discovered as a part of the skills assessment, whether this person is going to be able to continue to do the same sort of work that they were doing in the past. And if not, then we will consider changing their FCO to SSI or federal disability so that they can make that application. The DVEs are conducted by certified rehabilitation counselors who, at the end of the process, take into account all of the person's background, education, skills assessment, and come up with an individual plan for employment. At that point, the person enters the full vocational rehabilitation track. It consists of case management, job readiness training when needed. In certain circumstances, if an individual is ready to go for employment, we will fast track them to job developers. It's an interesting area in that they're actually supported by two case managers, if you will, or they have a regular case manager and they're working with a job developer as well. So there's a little bit more intense support for this particular track. The goals for this are to place somebody into permanent employment, and then under the performance-based piece of the contract, we pay the contractor for retention at 30, 90, and 180 days once the person is found employment. The program overall between all of the regions in New York places about 350 people a month on average. While they're in the vocational rehabilitation track, they also take part in what's called currently the Work Experience Program. This is actually a community service option where for part of their participation hours, they may work with nonprofits or non-governmental organizations in the area as a way of building resume and skills. When they leave VRS as a part of placement, they also receive transitional benefits. So they receive Metro cards or transit costs for up to 90 days. And then also as a part of the contract, the vendor provides them with incentive awards when they hit their 30, 90, and 180-day milestones. Otherwise, a customer could be assigned to the federal disability track. Again, in this case, we've gone through the sequential evaluation, and either by virtue of meeting a condition or by meeting grid rule qualifications, determine that this person is very likely eligible for SSI. In which case, they have, generally speaking, one meeting with a case manager where they bring in their documentation, and the case manager works with them to build a case and to submit their their application to SSI or SSA or SSI or SSDI. If it happens to be the case that the customer already has an application pending, then we will supplement that application with whatever documentation has been added to the case or whatever they got going through our own assessment process. We help them gather documents if necessary, and if they are unsuccessful in their initial application in getting SSI, then we also have a process by which the agency helps them to appeal their SSI decision. So that's an overview of the program overall, how WeCare works and how it works not only with people with medical but mental health conditions as well and substance use issues. Speaking about specifically mental health, what we found looking at data over the past 12 months is that 38% of our new WeCare enrollees each year had at least one mental health diagnosis. And I think that is more or less in line with the earlier statistics that we were seeing for TANF population. We have 16% of our new enrollees who had 2 or more mental health diagnoses. And 10% of our WeCare enrollees required a secondary psychiatric evaluation. So when they came through their assessment, they were deemed such that they needed to see a psychiatrist separately so that we could get that evaluation before making a decision as far as a functional capacity outcome. And one clarification that I would offer on these stats is these are clients who were specifically diagnosed part of the assessment process with these conditions rather than the clients stating that they had the condition. So there's medical input, if you will, on these statistics. We also took a look at the mental health diagnoses that we've seen most commonly. So we tend to see most often episodic mood disorders or neurotic disorders. To a lesser degree, we see adjustment reactions. We see, of course, substance use. Non-dependent abuse of drugs is at 6%, drug dependence is at 4%. Alcohol dependence, at least in our stats, it was only at 1%. And then we have smaller numbers of personality disorders, attention deficit, hyperactivity, and developmental delays. And these numbers also reflect comorbidity. So a client with multiple diagnoses would be in multiple of these categories. Looking at our actual FCO distribution, there is something of an interesting difference between clients without mental health diagnoses and those with mental health diagnoses. Generally speaking, you'll see that the numbers are very similar. We have about 40+% of people with wellness plans. We have about 4 to 5% in our Wellness Plus program. We have 2% that have no functional limitations. But where we do see a little bit of a difference is between VRS, our Vocational Rehabilitation Services, and those on SSI. And there's a shift of about 7 percentage points where we have a smaller number of people who are able to work with limitations. They've got mental health diagnosis, and a larger number of people going into the unable to work category. Outcomes specific to those with mental health diagnoses, of those who were assigned an FCO with unable to work during this period, 10% were ultimately awarded SSI benefits. And of those with mental health diagnoses and assigned an FCO with vocational rehabilitation, 11% of those were placed into employment. So clearly working with this population of individuals with mental health barriers to employment, we do have to have specific strategies in place to help them in their job search or their other work, such as wellness plans and SSI. We coordinate treatment and services with outside providers, including substance use. I haven't really covered it in this presentation, but HRA has an extensive line also of substance use specific programming where we offer intensive case management and regular assessment in coordination with outpatient and residential and harm reduction providers. That's not WeCare specific. We provide that throughout the agency. We also reduce required participation hours based on the condition, and we utilize excused hours for appointments and treatment. So if someone comes in and presents with intensive substance use concerns or a mental health condition, for example, where they require regular therapy, and we adjust their hours so that they can take part in those activities. We offer specialized job search to anyone with a medical or mental health condition. Rather, the job search with the case manager and with the developer is always tailored to what the specific condition is, what their functional capacities are, and what their functional capacities aren't. And again, as I mentioned earlier, we have ongoing case management in addition to working with the job developer when you're in the VRS DCP program. And that concludes my presentation or overview of the WeCare program, and I look forward to your questions at the end of the webinar.
Thank you. So now we will hear from Miranda Gray from Lisa.
Good afternoon, and thank you for this opportunity to talk to you about Vermont's Reach Out Substance Abuse and Mental Health Program. It's an emerging and best practice model adding substance abuse and mental health case managers and clinicians to Reach Out's teaming model. So to give you some background on why Vermont decided to start this program, about 1 in 5 TANF recipients abuses drugs or alcohol. Approximately 1/3 of welfare recipients have a mental health condition that may interfere with employment. And then nationally, approximately 50% of people with a substance abuse condition have a co-occurring mental health condition. So our purpose was to provide integrated substance abuse and mental health services for people in Reach Out. This was done by increasing access to treatment and case management through our designated agency system. In many states, this is known as the community mental health centers. When we were looking to what we would like to do here in Vermont, we outreached to our federal partners, ICF, to ask what are other states doing. We were connected with the MOMS program out of New Haven, Connecticut, and then Utah, who had clinicians already embedded in their TANF program. To give you some background, this is an Agency of Human Services interdepartmental program. The departments involved directly with this grant in Vermont include the Department for Children and Families Economic Services Division. This is where our TANF program is housed. The Department of Mental Health and Vermont Department of Health Alcohol and Drug Abuse Program. The program was implemented in 2 phases. In November of 2013, we launched this program in 4 of our 12 districts throughout the state. And then with the governor's help and the legislature's help, we were able to bring up the program in our remaining 8 districts in July of 2014. We work with 11 agencies across the state to provide services to our Reach Out participants. With few exceptions, all the agencies can provide both substance abuse and mental health services. And I should pause there to just say that we were given this opportunity to try this program really more so under the guise of the substance abuse that we are seeing so prevalent here in Vermont. So our initial model, unsure what would be providing the best service to our participants, we decided to place 1 substance abuse mental health case manager and 1 clinician in each of our district offices. Due to the nature of who can provide primary mental health services versus primary substance abuse services, the model looked a little bit different in each of our regions. We had to have memorandums of understanding created in certain areas so that it was very clearly outlined how we were going to collaborate together to provide the best support for our participants. So our initial model, each case manager and clinician were expected to be working with 35 participants. The substance abuse mental health case managers were also doing all of the Reach Out case management. So in addition to engaging in a therapeutic relationship, we were also asking them to create what we call here Vermont Family Development Plan. So what do you need to do in order to obtain your goal of employment? They were also implementing the fiscal penalties that are part of TANF law, that if you're not compliant and you're not engaging, will reduce your grant. Services provided had to be billable under the Medicaid fee schedule. Participants that were not willing to engage could not remain with these case managers and clinicians indefinitely because there have to be billable hours in order to sustain this program here in Vermont. Some of the services provided by case managers under this program included specialized screening and referral to interagency resources for assessments for substance abuse, mental health, and trauma, to facilitate and monitor treatment plans, facilitate and coordinate treatment team meetings, We coordinate closely with our hub and spoke programs, and in Vermont, our hub and spoke programs are closely tied to our methadone clinics, or are our methadone clinics in some areas. And then also to provide integrated service planning and coordination and specialized community support as outlined in the state of Vermont fee-for-service Medicaid manual. Clinical services provided under this program included access to evidence-based programs such as Seeking Safety, which is focused on attaining safety from trauma and or substance abuse, and Walking Horse. And that is a program for parents and mothers who are questioning their own use of alcohol or drugs or who experience the effects of another substance abuse behavior. Diagnosis and evaluation, emergency services, individual therapy, group therapy, as well as case reviews for each case manager, and then case consultations to reach out teams on a regular basis. We wanted our internal reach out case managers to have the opportunity to present cases anonymously to try to see, did the clinicians think that we should, how could we engage this participant, because it seems as though something was going on, and how could we maybe get them into this program. To help participants are identified here in Vermont, reach out case managers screen all of our new participants with an uncoded and PHQ-2. Positive results yield a referral for our substance abuse and mental health case manager and or clinician. Best practice is to hold three-way meetings to introduce the participant to the substance abuse and mental health case manager. And we are able to do this through having the substance abuse and mental health staff sit in our offices routinely. So currently in our agreement with the designated agencies and preferred providers, we've stated that they need to be present in our offices at least one day a week. But what we've found is that oftentimes they're present more because that is what we've found has worked to engage participants. Some of our challenges. One of our greatest challenges is filling the position. This is a really hard job, and the compensation isn't that great for these substance abuse and mental health case managers and clinicians. We're trying to navigate two separate systems of care. We have the preferred providers here in Vermont through ADAP, which can administer the substance abuse services, versus our designated agencies through the Department of Mental Health, who administer our mental health services. And as we know, clearly people have co-occurring, and if we're working with some of our agencies that cannot provide both. Determining what the connections to the hub should look like and how to begin that process. One of the things that we did not realize when we were implementing this program was how many of our participants are connected to a methadone clinic. We hadn't taken that into account. So as we've been working through this the past couple of years, we've had to look at how do our case managers and outside clinicians connect the methadone clinicians? What does that relationship look like? How do we make sure that we have coordinated treatment plans, not treatment plans that would be pulling the people apart? And also, another challenge is the funding. The grantees receive a very small amount of general funds to account for populations that tend to have more no-shows than others. And so they really are needing to focus on being able to get Medicaid billing to have billable hours. And that has been a challenge. Another challenge has been engaging participants with both the case manager and clinician. We found that when the participant has told their story, it's very challenging to then have to tell somebody else. And if they are first engaging with a case manager and develop a good rapport with them, we ultimately need to get this participant to engage with a clinician because we need to be able to get a diagnosis, create a treatment plan of which the case manager can then provide services and have those billable. We've also struggled with retaining staff. I think since we began this program in November of 2013, we still have only 3 staff that initially started with us still on board today. This is, a difficult program at times to have people engage in. And so that is something that we have seen, and they're dealing with a lot of people with a lot of trauma in their background, domestic violence, and so that takes a toll for the case managers and clinicians as well. Another challenge here in Vermont is gathering the data. We three departments, although in the same agency, have no common database. So it's really hard to be able to get information without that being a manual process and matching that up. And then also determining what is success. Everybody wants to know how can you say that this program is successful? And is success defined as, for TANF said, we've got them into treatment and now they're off working full time and they're no longer on assistance, or is success that we finally got someone to engage in treatment and they're no longer actively using. The last challenges that we found and needed to address was that it was really challenging for our case managers to build a therapeutic relationship when also administering the TANF rules. It's hard to get someone to open up to you when, if they're not engaging in the REJIP program, you then are part of them receiving a fiscal sanction. That brings us to our present day model. Some changes that we made based upon challenges that we saw. So 6 agencies are still working with a case manager and clinician model. So there's still 2 people to work with, but we have some areas where it is working really well. We have 5 agencies that have moved to having a clinical case manager model. This has allowed for participants to have to tell their story to one less person. They're getting participants are getting assessed sooner, and that allows us to be able to bill Medicaid quicker and have less time being spent with clients that isn't Medicaid eligible. We also, July of last year, decided to not have the substitute mental health case managers also administer the REJIP program. So now they are paired with an internal REJIP case manager, and they work together cohesively of what makes the most sense in terms of treatment. What can this person really be doing for their treatment, and outside of what can we be asking them to engage in? Is engaging in community service placement at this time something that they can really do, or do we need to focus on getting stabilized and then working on attaining support skills? So the role of central office in this program, so one of my primary roles is I coordinate face-to-face community practice meetings. So essentially what this is I bring together all of our providers, our supervisors, our staff that are doing this work, the clinicians and substitute mental health case managers together to talk about what's going well, what are some challenges that we're facing, what training do they need. We've identified that we had a population that had significant trauma, that we had a significant amount of domestic violence. This is something that our case managers and clinicians felt they needed more support around. So we made sure that we brought in trainers to be able to give them these resources so they felt more comfortable and capable of going out and working with our participants. I also coordinate management team meetings in every district. So I pull together all of the supervisors and workers as needed to really drill down on what's going well in their area, and if there are some things that are really challenging, how do we overcome those together? And then I've also been working to find ways to collaborate with our Family Services Division because we have seen a significant amount of caseload overlap just between our TANF and our Child Protective unit. The data that we're currently tracking includes the number of screens. Of the number of screens, the number of screens positive for substance abuse and mental health, the number of effects and how quickly, of the number of effects, how many needed treatment, and the number referred to treatment, the number initiating treatment and how quickly, and the number receiving treatment services. These were ADAT measures that we decided to use, and moving into our grant cycle this next fiscal year, we're looking at how to tweak these because what we found is a lot of this is contingent on human behavior. So we're looking at how many were assessed and offered an appointment within 3 days. So what we found is we have some people that aren't ready. Although we've identified they screened positive, they weren't ready at that moment to engage in treatment. And so it might not be, 3 days out that they can keep appointment. It might be 2 weeks. It might be a month. And we didn't want to penalize our partners for this. So attached is a graph that we shared with our legislature this year that shows that 64% of participants became engaged in treatment after being screened by our contracted staff. We felt that this was significant, that we are identifying those that need treatment, and we're able to get about 64% of those that we've identified. That concludes my presentation. If you had any further questions, I would be more than happy to talk about our program further. Thank you.
Thank you very much, Miranda. So at this time, we're going to ask our final polling question, the third and final question. Does your program currently have a formal effort in place for addressing mental health services or mental health issues among program participants? Okay, I'm not sure what's going on with this one. Okay. So I just want to say thanks to our wonderful presenters who provided a wealth of information that we can all use as we work with TANF families. And now we're going to open up the session for questions from those of you on the phone lines or the webinar. There's one question. I see Marcia Bentley had a question for you, Tim, and her question is, how many SSI appeals will WeCare staff assist with before they determine that the client might need a different plan?
We will continue to work with them, and even throughout the appeal process and post-process, to apply for SSI if we still feel on a clinical basis that that is the most appropriate track for that person. So when you apply for SSI, it's all about how well the case is constructed and documented. So you go through the process of the initial decision, then you can have, if that's denied, you can do an appeal, and there's also an administrative level appeal after that. If the client continues to be denied in that process, and they come back to us for assessment at that point, if the assessment comes back as an SSI, we will continue to keep them in that track. I hope that answered the question.
Thank you, Tim. Okay, so we'll just give a few seconds here and see if there are any more questions. Like there's a question. So if a client is receiving SSI for her child, can she still apply for TANF? And I think Miranda or Tim can tackle that one.
She should still be able to apply for SSI, but of course, TANF application is all about family income, and SSI does tend to be higher level of benefit than regular TANF benefits. So, depending on family circumstances, at the end of the day, the application might not be approved, but it's all really going to be case specific.
in Vermont, yes, a mom with a child receiving SSI would be eligible. We would say that the child still makes them eligible, and we don't look at SSI income for children in Vermont.
Wonderful. And here's there's a question for Vermont. How do clinical case managers deal with the inherent dual relationship, i.e., the clinic case managers monitor participation? So,
Sorry, go ahead. How do clinical case managers deal with inherent dual relationships? I think what we've found is that, that can be a challenge, but we found with our participants that not having to engage in a relationship with two people, and maybe it's a bit unique to Vermont, but my understanding is a lot of clinicians are doing case management work anyway, helping clients navigate other areas of their life. If it is that they don't know how they're going to pay their rent, this month, that they're kind of stepping in that role anyway, and this just allows for that to happen more naturally. That not being a clinical case manager myself, I'm not exactly sure how, to be able to speak further, but that's my understanding that, where we have this model, it seems to be working better just in terms of one less person for our client to have to talk about their story with.
Great, thank you. Okay, so we're going to just see if we get more questions. Here's a question now. When a client is denied for SSI, where would they get the information to appeal? Is it online? Tim or Miranda?
I'm not sure here in Vermont because we contract out for those services. I'm not sure, so I would defer to Timothy as that answer.
I don't have the information. I don't know specifically whether it is online. I would suspect that it is on the SSA website, but I can't answer that definitively. For us, from a programmatic perspective, we actually have a unit that helps them with that appeal. So long as they have not elected to have separately what's called a plaintiff rep, which is like a vendor or someone like that who may be taking the case for them. We have a specific unit, so we help them with that actual appeals process. But from a public perspective, just Joe on the street, I would have to think it's on SSA, but I can't say for sure.
And there's a comment from Indiana saying that they actually give a paper application. It says it's very simple. And I know in Washington State, they have hearing officers for that, and also do some contracting out with attorneys, but it sounds like it varies from jurisdiction to jurisdiction. And someone else has commented that you can appeal the decision online through the Social Security website. Okay, so I have a final question, I guess, or if there are any more from the audience. So I just want to ask the panelists if they just want to offer a piece of advice for TANF programs interested in better providing mental health services to TANF or low-income participants. So in addition to all the wonderful, very rich information that you've already provided, if there's just like a of, a takeaway that you want the participants in this webinar to leave with, that would be great. And so I'm going to start with Dr. Spooner since she led us off, and so we'll just let her answer first.
Yeah, in terms of advice for TANF programs, I would suggest that in the light of what I've presented today, it's important to think about families and TANF recipients as persons who are willing and able to seek mental health services, but require as much support as they can get. And also to think about how agencies can build in a strengths-based approach to services, making services culturally appropriate, and just ensuring that the services are beneficial to the whole family. And, with all of the services, there are stipulations and guidelines, and it's important to understand how those can be applied and might be applied. I think in terms of mental health services, it's not always as obvious, because like I explained, the need for mental health services are not necessarily connected to violence or particular behaviors. And it's about doing that screening and helping recipients and families to think about how they plan around identifying and using the services they need. So that would be my takeaway, Carol.
Thank you. Tim?
I think the one thing that I would offer as an observation or as a piece of advice is it really is not an either-or decision in terms of balancing treatment for mental health conditions or any medical condition and inclusion in a workforce development program to get the client back to work. In fact, I think the integration or the collaboration, if you will, between the two is really instructive to any client who has such a condition and how they're going to be able to balance their life going forward. Because, in many cases, a mental health condition is not necessarily going to resolve itself. And even if they do, or when they find employment, it's something that is going to have to be balanced against the other demands in their lives. So I think, my recommendation or my hope or my observation would be that we find ways to make sure that we have a fully integrated model that ensures that people are getting these mental health services while at the same time, to the extent that their condition allows, obviously, that we keep them moving in the direction of employment ultimately, as that's what's going to serve them best.
Wow, thank you. Okay, Miranda.
She was a hard one to follow. So I guess my last piece of advice is if there is a way for you to find a way to embed some of these mental health services into your program, I encourage you to do so because I think it's going to help people by getting these barriers addressed. It's going to help them to find ways to employment, or maybe it's going to identify that the Social Security route is the one that we need to be pursuing. But it opens up other opportunities for our participants to be able to move forward and become more self-sufficient, and hopefully, one day not need our services in the same capacity that they do today.
Great. Wow. Well, this was very, very enlightening. I think mental health, when we hear that, is very intimidating, and you have all these different thoughts go through your head, and you think about the material, and sometimes it's presented in a real dry manner, and So, but this, you all, the presenters, I just want to say thank you because you guys definitely exceeded our expectations here at OFA. It was very informative, and I think from the questions, it was also engaging, and the folks that participate in the webinar, I want to thank you again. And as far as the audience, that was thank you for calling in. And I just want everybody to just remember that to provide your feedback on this webinar using the survey that will appear in a separate pop-up window when the webinar ends. And also a transcript and audio recording of this webinar will be available shortly on the Peer TA Network website, which is at peerta, and that's one word, .acf.hhs.gov. We would like to just hear from you as far as any future webinar topics. If you have thoughts or ideas or things that you just would like for us to research and present, that would be great. And you can send your ideas by email to peerta. Again, that's one word, at ICFI.com. And then, as always, we've mentioned this before, but we're looking to expand our network and reach a greater number of people. And so we would appreciate if you would just direct your colleagues from your local and state networks and agencies to our website. And again, that website is peerta.acf.hhs.gov. And we look forward to your participation on future webinars. And again, I would like to thank all of the participants, and definitely I'd like to thank our expert presenters.